for the next hour. Firstly, I'd like to introduce our panelists for this evening. First, a social worker of 10 years, currently working as a director of Family and Youth Services and a former candidate for Lafayette City Council in 2019, Kara Boyles. Welcome, Kara.
Thank you.
Next, I'd like to welcome Loretta Barnes, who's a candidate for Indiana State Representative District 13. She's also been a marketing manager for 10 years, and one of her main issues is mental health and helping people with mental health issues. Welcome, Loretta.
Hello, everyone.
And last but not least, the host of our event this evening, Joe Mackey, who is running for Indiana's 4th Congressional District for Congress. Welcome, Joe. And by the way, you received a new endorsement today from the National Association of Social Workers. Isn't that right?
Yeah, it is. That's the timing couldn't be better. We appreciate the fact that they're supporting our campaign, and I'm ready to talk about mental health care and social workers.
That's wonderful. And just real quick, I just want to read part of this endorsement. I won't read the whole letter. It was I think it's a very nice letter. I assume that you felt that way as well, but I just want to read part of it. And this is from Mary Jane Lundgren, who is the chair of the NASW PAC. And she said, I am pleased to announce that you, Joe Mackey, have received the endorsement of the Political Action Committee of the National Association of Social Workers for your 2020 general election campaign. NASW membership of over 110,000 professional social workers, including our Indiana chapter, join me in extending support for your campaign in light of the commitment to the well-being of individuals, families, and communities you've shown. So it's a wonderful thing, Joe. I really appreciate it.
Thank you.
All right, guys. Well, what I would like to do is just jump into some of the questions, and I'm going to start with something very timely. Obviously, in this time of COVID, it's on all of our minds. There's lots of concerns and fears out there. And so in light of COVID and the fears that we have or people have with avoiding the disease and the subsequent efforts to socially distance from loved ones, what can public policy steps be taken to meet the needs of our communities in a post-COVID world? And I'm going to leave that open to whoever would like to jump in.
Well, I'd be happy to just speak to what we're currently seeing as far as the shifts in mental health and the allowances that have been provided, and just, how I see that this could be continued and how it's kind of layered, right? And so COVID allowed us to see some gaps in certain areas, but one of the things that was loosened was the ability to use virtual services. And so historically, virtual services or telephonic services have not been considered billable services for a provider under Medicaid, Medicare, HIP, or other insurances. In light of COVID, they loosened those restrictions and said, you can use virtual means. You can use virtual and telephonic means to ensure we're addressing people's needs in the moment and to pivot and readjust to this new world we're living in. What we're all in fear of, though, is this has been so incredibly successful for all of us as providers throughout the community, and we've seen this enormous impact in ways we couldn't have even imagined. But one of the things that we're concerned about is once things are returning to somewhat of a normal, a new normal, and the loss of that telephonic ability, right, or that virtual ability. And so ensuring that that is something that is now embedded in policy around Medicaid, Medicare, HIP, to ensure that anyone receiving those insurance benefits and then receiving mental health services covered under those insurance policies can then, those providers can continue to bill for virtual needs and telephonic needs is incredibly important in order for us to continue with these. Again, it's been wonderful what we've seen.
If I might. Oh, Loretta, do you have something to say to that?
Oh, I was just going to say that that's one of the areas that I think that we need to build up our whole infrastructure for telemedicine. And I think along with helping people with the COVID crisis, that it is a great thing for veterans especially ones that live over 40 miles away from the closest VA. And I'd like to see us put policy in place that ensures that veterans and people that don't have as good access for transportation, this will allow them hopefully to get treatment faster or get services faster.
So if I might, Kara points out a revolutionary change in the way that mental health care is being delivered. And it's a wonderful change. I don't see it going away. I think the world has evolved, if you will. More and more people will find themselves working from home. The e-media outreach is not going to disappear. I don't think you can put the genie back in the bottle. But I do have concerns in that, especially where our rural brothers and sisters live, where we don't have high-speed internet, phone signals are iffy at best, and we witnessed, as Kara pointed out, we pivoted right away to the e-medias for outreach, but we don't have that access in our rural communities. And I think that it's important to understand that the needs of those folks are not being met. And when we experienced the COVID-19 shutdown, our fellow Hoosiers out there in the rural communities were really isolated, even more so than normal. And I think, you know, I'm happy to hear Kara's report here, because it clearly points to an opportunity to do more, I think at less expense. So I know in the next session, discussions like this are going to be taking place. So I know they're going to happen. I plan to be there to be a part of them.
Joe, as I hear you talk about that, it reminds me of—
And Joe,
pardon. I was just going to say, part of that platform around education and the importance of every school age child having the ability to have internet to do their homework, but it's just as important from a mental health standpoint that their parents and them themselves, the children, can see a mental health professional, especially in rural
and healthcare overall. You know, we pivoted to telemedicine, and of course that's not happening in the rural areas either. So we have a very modern world and a very isolated population of people that are not extracting the benefits that they should and are due access to.
And with rural areas, one of the things, because rural schools don't have as much money, one of the things that suffer first is lack of social workers or therapists in the school. And especially now with COVID, I think it's very important for kids to be able to talk about the stress, the unique stress that this has brought about. And I think that that's a policy I would like to see a lot more funding to getting nurses and social workers and therapists in the schools.
Absolutely. And, you know, you both speak to the rural communities, and, you know, that's something that we've seen for people who do have access to internet, or, you know, the ability to access, you know, Skype or Zoom. We are seeing this reach that we've never had to those communities, and providing like diversity in services. And so one of the things in our rural communities is we may have one therapist or one therapy office within the entire community. So say someone goes to that office and there's only one therapist on staff and it's their aunt. They can't see that person. So now they're having to go outside of their own community in order to seek mental health services. Likewise, if you burn a bridge. So, you know, some providers have a no-show policy, and you can't return to services if you violate that no-show policy. And that's just a reality amongst, you know, mental health and providers. And so if you've burned your bridge at that provider, and that's the only one in your community, where else do you go? And so our ability to be here in Lafayette and stationed in Lafayette, and so many of the providers are, but we have this reach now, and we can be right there with someone in a rural community, and now they have access, and now they have choice, and now they can go somewhere else and have more choices in order to access a provider that's truly going to meet their mental health needs. And so that's one of the things that we've seen, just this expansion of our services and our ability to serve so many more people. It's just been really incredible. That's been one of the true benefits to all of this. It's something I don't know if, we might have gotten there eventually, but this kind of forced the situation, and it's been really wonderful.
If they have the internet in order
Absolutely.
to be able to do it.
Right. They have to have the tools in order to be able to participate.
Absolutely. Absolutely.
I mean, we have areas in this district where 60% of the population have no access to internet, have no telephone service. They truly are isolated, and like the rest of us, they work and pay their taxes. Only they are not extracting, as I said, the benefit of the taxes they're paying. So we have some work to do. We are seeing an advent, this technology, this remarkable new outreach. I have a question, and that is, are you finding your workload growing as your outreach builds?
Yes. Yes. And so one of the really great things, though, is what you mentioned is cost effectiveness. And so time efficiency is one of the other things that we've seen as well, because when I'm not driving 30 minutes from the west side to out to Americus,
Right.
30, 45 minutes, I'm able to just, providers are able to go back to back, right? And so they may take a nice little break in between, get some water, go to the bathroom, and then they're back on another call. And so we have this ability to serve more people in a shorter amount of time because of this time efficiency that we're seeing with the use of these platforms. And so, especially with providing home-based services. The other thing we're seeing too is, you talk about barriers. So access to internet, but for a lot of people, transportation can be a real barrier to accessing mental health services. And so getting to the appointment can be a struggle. And so now we're seeing a decrease in our overall no-show rates. And so our no-show rates are decreasing. People are present, they're receiving the services that they are needing. And we're able to then serve more people in a shorter amount of time because we're efficiently able to use time. I mean, it's just overall, we've seen this just overabundance of just wonderful outcomes just from such a negative circumstance.
Experience. Right.
Yeah.
Right. Congratulations. Congratulations.
I can imagine people can go to work and then get therapy on their lunch break, or get a case management session on their lunch break, right? Something like that. Don't have, because in the past you would have had to meet with somebody and then they don't want to meet their caseworker at work. I get that, but heck, if you can get on your phone, that's wonderful.
Yeah. And I really think about too, how this could expand into emergency access to services. And so, just being able to get someone in a crisis moment, right? And so this is so much easier to reach someone in that crisis. Now for me, one of the things that I struggle with is I love this new ability to access people and provide options and choice. I am still like a person who wants to be present. I think there's something about human connection. And so, sometimes that virtual option in crisis won't always be available or appropriate for the situation, but just the thought that that's an option, that could work for other people, and it could work in certain situations.
I can hear the, I don't say older folks, or maybe people that aren't sure about new technology asking, well, how do we know that this is safe? How do we know that this is truly confidential? I don't want somebody, people can, we talk about people can get into Zoom meetings, get into the wrong Zoom meeting, hear what's going on. What's going to stop somebody from getting in a therapy session or talking about your drug use or some of those kinds of things? What kinds of steps need to be taken, or what are being taken to ensure that this is a safe thing moving forward?
Sorry, I'm so sorry. Buddy, can you go out for a second? Okay. My 4-year-old came to say hello. Can you go for a second,
Hello.
please? Go find daddy, okay? I'll be out in a second. All right.
My dog was actually nudging me here a moment ago, and you probably saw me kind of wink away.
Okay.
So,
He's
if I
gotten very
might-
used to saying hello on Zoom meetings, and usually. So, Kyle, you were talking about, can you remind me? I'm so sorry.
The importance of confidentiality and how
Yes.
how can we trust this is a safe system board and what can be done?
Yeah. And so that's something that, we have been assessing, I would say throughout the entire community. So it's very clear that Skype and Zoom are not secure platforms, right? And so we have this loosening of restrictions right now, and we have the ability to use them. Now, there's consequence potentially, but as a part of these policy changes, there are companies that are certified, through SAMHSA and, all through these accredited bodies to be secure. And so we have platforms that exist. There are platforms out there that can be purchased, just like Zoom, that are secure. They're platforms that are not going to be a breach in confidentiality for the individual. No one can hack into, and that really do protect that person's health information, and that is really important. And so, we do have this loosening right now as a need, as the need rose, and we weren't prepared. But I see moving forward that not just being able to get on Zoom and do a therapy session, right? That could be really damaging for that person, and their personal information could get out. But then integrating that it should be a certified or accredited program that's used in platform.
So you probably need policies in place to ensure that that's happening equally throughout the state.
Yes, because you could, it would be really easy to, especially because, frankly, they're not as cost effective as Zoom necessarily, right? And so Zoom is designed the way it is. It doesn't have the layers of protection that, that these other platforms do. And those other platforms, so you're paying for what you get. And so you should be putting a little more weight into this, right? And there should be, a little bit more security in that and financial cost. And so that investment is important to do this. But yes, I would say to ensure that everyone is doing it throughout the state, and that a rogue provider is not just setting up on Zoom calls and accidentally hitting Facebook Live, right?
Okay. Any other comments on this topic, or are we ready to move on to the next question, guys? All right. So we talked a little bit about accessibility to mental health being really important. And though mental health issues affect people of all races and genders and economic groups, some communities are more marginalized than others, not just through accessibilities, but for other reasons. And we want to make sure that our communities that are at that greatest risk still have access and the ability to seek out mental health services. How do we meet the needs of our citizens and avoid marginalized people further by not allowing or not making the right situation so that marginalized communities can get it? What can we do?
Well, do you guys mind if I go?
Go ahead.
All right. If you look at it, they're already marginalized because of things like racism, discrimination, or trauma that has happened to them. They have PTSD. So then if you add the trauma or stress of COVID on top of it, they have higher levels of anxiety and depression. One of the first things that I would like to see as a state representative is to pass a real hate crimes bill. One that addresses and includes age and gender identity. Another thing I would like to see is increase access to mental health across rural and low income areas. Expand the crisis intervention team because it struggles a little in the rural areas. and add trauma sensitive training for school staff, so they can recognize that this child's not just acting out or acting bad, that there might be some things happening at home, or just the daily living and traumatization of being marginalized. There are other needs, and then there are probably other solutions that work better for that child rather than just being seen as a disruptor. So those are some of the things that, and we must ensure no matter what policies we make that it's applied equally, and recognize that marginalized people and marginalized children will take extra money, extra effort, both in school and elsewhere, in order to meet the same levels and have the same chances to be just a kid.
Mhm. Mhm.
Thank you. Other thoughts?
Well, and so I talked a little bit about, diverse access. And so, typically there is, so community mental health agencies across the state are, and elsewhere are tasked with providing services in communities, right? And so one of the things you see in higher populated areas is just you'll have your community mental health agency, but you'll also have other providers available. And so ensuring, that we have a diversity of services in those different rural communities and in areas, and continued access to diverse services, even in our highly populated areas. What we're seeing is this shortage of providers, right? And so just like in the healthcare industry, we do not have enough therapists to meet the needs of our country. We don't have enough therapists to meet the needs of our state. And I will tell you right now, there is no incentive to going back and getting your education to become a therapist at this point.
Right.
And so several years ago, they passed some legislation around loan forgiveness, so student loan forgiveness for individuals who work in a nonprofit field for 10 years after graduation. That is so nuanced and so difficult to actually achieve that it's almost unachievable, that it's become laughable within our work circles, that's no one actually gets that, right? Like no one actually gets their loans forgiven, but everyone's told that that's incentive, right? And so it's just, there's so much bureaucracy behind it, and there's so many caveats that makes it impossible to, with an education, to navigate that. And you have to fall into these such specific buckets, and you have to hit it at just the right time. And if there's a lapse here or this there, you're kicked off. And that's 10 years of not making wages that are competitive at for-profit agencies, right? And so we all don't get into the work for the pay. We get into it for the love of the work we do and the care we love giving to people. That being said, at some level, that becomes exhausting. And especially when you're not able to meet your own needs or your family's needs financially. And so, I think about true incentives to get more people into the field. There are plenty of people who have the heart for the work. There are plenty of people who would love to do it. We need real policy that isn't just, this, we're going to say we've done this and it's supposed to help. We're, making actual policy changes that do help people in the social service.
So let's talk about some of those policies. I know under the ACA, each state was offered money to expand mental health care services.
Mm-hmm.
Those were not expanded in Indiana because then Governor Pence did not believe in mental health care. I believe his exact quote was, if people go to church, they don't need mental health care. And so the money never came. And that is key to the shortage that you're speaking of.
Mm-hmm.
At the same time, I understand the state, the way they dole out Medicaid dollars for mental health, you are required to have an advanced degree, a PhD, in order to get that money. And therefore, we have plenty of qualified people who maybe have master's degrees, but cannot get access to the Medicaid dollars that their patients require. So we've kind of created our own bottleneck here in Indiana. And as a result, we see the shortages you're speaking of. I do think that we need to encourage education. I think we need more social workers. That's a given. I think we can do that, but it would have to come through an education bill. I would like to incentivize higher advanced degrees, pursuing at advanced degrees. I think that that's a benefit to all of us. But I do know that in the healthcare bills that are at least being passed around in the Democratic circles, mental health care dollars are being hardly defined, so that we know there's money out there that could come our way. And I think in the next House, providing we see how this election cycle goes, I think you're going to see some of those policy changes and finances will come.
Joe, can I, as a follow-up, how would you incentivize higher degrees? What are you thinking of there when you said that?
Well, so I'm thinking debt forgiveness. Kara mentioned it, although the situation is far too nuanced. And so there's all these caveats, as she mentioned. I think we can do better. I think we can do better for 5 years of service. I can see that this same program, we talked about this, a very similar program for educators, for teachers getting into the field, and debt forgiveness. So I see the opportunity there to expand that, and we should. And there's no reason why we can't. We know we can afford higher education. We can make it more affordable, but there ought to be some kind of incentive to pursue beyond your bachelor's degree.
What if you tied funding, loan forgiveness to, say someone's going for their higher degree, but if they work part-time in rural areas that don't have therapists, that they get, by doing that, they are getting some of that's part of the requirement to get some of their loan forgiven. It's not some great big requirement, and it fills a need in an area that just is
Lack of service, right?
Yeah.
So, and we had AmeriCorps. And it was almost the Peace Corps turned inward. And every 20 years or so, AmeriCorps gets a new life, a rebirth of AmeriCorps. And I think that's, Loretta, you just like kind of lit a fire there that we could quite literally do this. We've done it in the past, and I think that maybe it's time we revisited AmeriCorps, an AmeriCorps type program.
The same with healthcare providers, to fill the areas that we need. And they already do it kind of, if you're teaching certain areas that you can get certain funding. But I think that like doctors, healthcare providers, social workers, therapists, if they can fill a certain area that is in great need, then it's good for the whole state. It's good for the community, and it's good for the state.
So, I talked to a number of physicians, and one of the things we know right now is the United States is 92,000 specialists shy of meeting the needs of the American population. And one of the greatest problems we have is physicians are graduating from medical school. They're typically $300,000 in debt, and they do not pursue the more advanced medical degrees. So they stay in the GP family, if you will, family practice. And certainly we need to incentivize these talented people. And it's the cost that's the prohibitive factor. It's
Mhm.
cost.
Yeah.
And so, they don't see the investment in
Mhm.
that advanced career as being of value, of greater value. They surrender family time, years of their life. They're really put in a crunch. They're really in a situation where they have a shorter period of earning time to earn their living and pay their debts. And I'm all in favor of this, especially where we're saving lives.
Mhm.
So certainly, Loretta, you're onto something, in regards to incentivizing, getting our American physicians to pursue the advanced medical licenses, the medical degrees. I
Mhm.
spoke to one young woman. She wanted to be a stem cell transplant physician. We were discussing genomics and genomics, and it was her passion. And she told me she was going to be $1 million in debt before she would complete her education and her training. And this is the kind of commitment that we're asking of these younger people. And so I understand the prohibitive cost. We certainly can address that.
I think about, two things you mentioned. So, as far as Medicaid, you are correct. So currently in the state of Indiana, in order to bill to Medicaid and be a Medicaid provider, you do have to have the oversight of someone with a PhD. So a psychiatrist typically in particular. Currently though, the state of Indiana is looking to revamp that in order to allow for an LMHC to be that oversight rather than a psychiatrist. Is a huge shift, and we're really excited about that because that opens the door for many providers who don't have a psychiatrist on staff, who do have someone who has their LMHC. And so one of the things though is like we're always wondering if those things will actually happen.
Right.
If it will actually come to fruition. And so making sure that does happen, because I will tell you, and then even then, what Medicaid does pay out isn't much, and so it's actually not the cost of what we are incurring as agencies in order to provide service, and so increasing the coverage, so increasing what's paid out to providers in order to be able to provide livable wages for individuals who are providing therapy and social services is important. This decrease in qualification is really great. But again, we look at it and we're like, is it really going to happen? Because all we've seen is an increase in specified qualifications throughout the state of Indiana for us to continue to have contracts. And so for example, state agencies are not required to have the same credentialed employees on staff as independent providers are in order to receive state dollars. And so we've seen in just my time in the social service field, we went from someone with a high school diploma, but that had been working with children and families and in different capacities because a degree wasn't required for so many years, if they had 10 years of experience, they could provide the service. And you have someone who has all this historical knowledge and they have all of this experience and they have all of this, like boots on the ground experience that you can't get from someone who's never done the work. They're no longer able to provide the service, right?
Right.
Now we went from that was acceptable to it's a required bachelor's degree in a specific field. And if it's not or in a specific degree area, if it's not in that specific degree area, we're having to go through people's transcripts and total up the number of specific classes that they have and make sure they reach a specific total in order for them to do the work. And so you may have a human services degree, but that may not qualify in certain areas, right? And so the human service we're having to tally it all up to make sure it does. And so I'm not saying that we shouldn't have people who are educated and who are competent in the field. I believe firmly we should. Social services is a tough area that isn't something, and we're serving people who deserve well qualified people. We're serving people who deserve well qualified people. But when you're incurring $60,000 in debt to get a master's degree, but you're only going to make $40,000 a year, that's
right. Well, and you know, we have at the same time, we have working people with insurance, healthcare insurance. I have experienced this, and the healthcare insurance provider then says we will pay a portion of 3 visits to a mental health care provider, and then after that we're done. And so I don't know of those that are in need of the mental health care services are actually being served well by a limited number of visits. At the same time, and I must say, my former employer actually had an in-house mental health care therapist that you could see on the in-house. Actually, you didn't have to leave the facility, as Kyle said. I would like to see more of that kind of action. So, you know, these smaller firms who maybe cannot afford to hire a therapist, a mental health care therapist, perhaps they could burden share with other small facilities. We could make something like this happen, such that 2 or 3 small facilities might be able to hire an employee to come in or contract to come in and provide this service to their employees across the businesses. So there's things that we can talk about in a way of actually opening the door. But I definitely think that the health insurance industry needs to be made aware that mental health care is as valuable and as valid a need as any other medical health issue.
Yeah. And Joe, that's I'm sorry, Loretta, that's really important too, because I know, you know, when we talk about Medicare for all, when it comes to mental health services, it is even more important, in my opinion. And so you talk about people with private health insurance. And so in the time that I've been in the social service field, we've seen this expansion of individuals on HIP, Medicaid, Medicare have access to services in the mental health realm, substance use services that we hadn't seen before in just the time I've been in social services. But people who have private insurance, those individual therapists have to be able to meet the licensing requirements for that specific insurance agency and be signed on as a provider for each insurance agency in order for people to be able to access those services. And so, and you have to have more credentials in order to provide mental health services to people with private insurance versus Medicaid, Medicare, and HIP. And so we have this enormous gap for people who are privately insured, and then also payment through co-payment. So not even, you know, your insurance provider may cover every session you need, but they may only cover 25%.
Right.
75%, depending on your coverage. And we're seeing people reaching out to us saying, we can't afford that.
Right.
We can't afford to send our child once a week. I can't afford to go once a week to a therapist because that is my groceries. That is my water bill. That is my gas money. And I am in such a tight budget that I can't make room to pay for mental health services. So there's this enormous gap when people are paying health insurance companies an enormous amount. And so, you know, I think about like just kind of tying it back to Medicare for all. Medicare for all is healthcare, but mental health care.
Right, exactly. It's a very comprehensive view of the healthcare industry. So,
if you think about it, it's a vicious cycle. What happens is if somebody's like severely depressed and they have a job, But then they can't keep their job because they're severely depressed. And because they couldn't keep their job, then they don't have insurance. They can't pay for mental health services in order to get their job back. So it's this cycle of they can't pay for the medicine that would help level them out to where they could be productive members of society and get their job back. So they can't afford the medicines, they can't afford the therapy. And so we have this person who then can't be a productive member of society when they otherwise would have been able to.
Well, and again, if you look, those people in desperate need of mental health, if they come in contact with the law, they get it. So, in order to actually receive mental health care, you almost have to come in contact with the law. You have to become problematic. And then, within the jails, then you do have access to these programs. The idea is to give them access to these programs before they get into that kind of have that kind of contact with the law.
If the law enforcement officer has had the proper training and knows how to handle someone with a mental illness,
Yes.
Otherwise they might be laying on the street with their hands up in the air and get shot by a police.
Get shot. Correct, Loretta. Absolutely.
I'm curious, how do you feel, all of you, how do you feel about employing more social workers specifically for mental health calls that are made to 911? More of a social worker taking the lead. I know in Ohio, Columbus, Ohio, they've done some of that. I know in Bloomington, there's at least one officer that's, I don't even know if it's an officer, it's just a social worker on the Bloomington, or I believe IU police force. What do you guys think about that?
I think oh, sorry, Jeff.
No, go ahead,
I
Loretta,
was gonna
please.
say, I think it's a good idea if they're part of like the crisis intervention team. Like there's a law enforcement officer and a social worker.
Yes.
So
Yeah.
just in case that there are issues that need the law enforcement officer, but the social worker in that instance would take the lead.
I would almost, and I agree, Loretta, it should be teamwork, or at least look at hiring and training police officers with education in the mental health care fields. I think you get the best of both worlds. I think that if we just take a different a view from a different perspective, if you will, I think we can answer a great many issues that I mean, our police officers are being deluged. They are expected to handle such a broad array of the social issues that we see in the news every day. So I do think that, Loretta's right. It needs to be done in teamwork fashion, where we have someone that perhaps is well educated and trained in de-escalating an elevated situation. But we also need to understand that they are in dangerous situations and must be able to protect themselves and the innocents around them.
I'm going to go rogue.
Go rogue.
So I don't believe we should be calling police officers in these situations. So I think if we had an alternative option, so instead of 911, we had 611. And if you are in a true crisis where you have a child who is having a meltdown that you don't know how to handle, if you have a relative who has you don't know what to do for them and care for them, you're calling a completely separate entity. And I think providing individuals with the option to assess what the needs are in the moment and not involving law enforcement, because that's the only option right now. And so I will tell you, when it's the only option, what are you supposed to do, right? What are you supposed to do if you have to call the police? And I will tell you, I have heard stories about children jumping out of second-story windows in a crisis situation to get away from a police officer because of being re-traumatized by them just being in their presence. And so you talked about having to run into law enforcement in order to get mental health services. So if we know that that's the case, the number of people who have had those run-ins, they're not positive, right? They're still in trouble. This could be re-traumatizing experience if they're having to call the police and they're hanging over there and they're in, they're there and they're there to jump in. I will tell you, I've been in plenty of situations where I have been in people's homes that I've never met before, that are in the worst situation of their entire life. And I have never once felt threatened or unsafe or like I couldn't handle the situation. And I will tell you that is by and large everyone in social services. We go into homes where we don't have a gun. We don't have pepper spray. We don't have anything to arm ourselves. We walk in with nothing, and we're present and we're there and we can de-escalate and we can serve people, and we don't need any kind of authoritarian figure to keep us safe or that person. We can do it independently. And so I will tell you, I'm going rogue. I went rogue. I told you I would.
Okay, I agree with
law
you.
enforcement is an option. I don't think law enforcement should be involved in these situations.
And all I would add is, for what it's worth, Kara and I have done similar things in the past. I've worked in this field for 10 years. I've never felt threatened either, and never felt like I needed a weapon to deal with the situation or unsafe. And when I worked at the Department of Child Services, we had the option to contact police if we needed assistance. Those were few and far between that we ever needed to do that. That was if we felt a child was about to be removed. And that's, of course, a very tough, tenuous situation anytime. But generally,
and even then, even in those situations, it escalates things rather than de-escalates things.
it does.
So when you walk in as a person talking to a person, and then if you walk in with a law enforcement officer behind you, that indicates fear.
Yep.
That indicates fear. And that then stigmatizes that individual. I am not fearful of the people I have the privilege of serving. I'm there to be with them and alongside them. And I think involving law enforcement altogether, I think we do need this alternative option. And so I think about this mother in Salt Lake City with the autistic child who was shot by the police, right? And so obviously that's devastating. That, whatever happened, that's devastating. But that mother had no other options. She didn't know who else to call. If she had another option, do you think she would call the police? I don't think she would have. And so creating this whole other entity and alternative to respond to, people who are in crisis. We have a lot of like suicide hotlines and things like that, but there are people who need to be with that person or see that person or get that person to safety, right? And just having those people on hand, on call, who can respond in the moment when their autistic child is having a meltdown and they're bigger than their parent, and because they're an adolescent and their parent can't get them under control and they're going to harm them or someone else or themselves. They need someone else to call. And obviously calling the police is not working.
That's an excellent point. I agree with what you said, alternate option. I like that idea, and you changed my mind.
Well, let me, because this discussion we're having, and obviously, Kara, you've had this discussion with others in your field. Is there an opportunity out there to expand that to the broader community, these ideas? I mean, are you seeing, is this just a discussion you're having within the healthcare family you work with, the social workers, or is this actually something you're discussing outside of that circle of friends, and what's the response that you're getting?
I think that, it's something that that is, obviously been mentioned in other areas. So like if law enforcement's sending a social worker out, like I think there's differing opinions on what can work and what will work. I think about, though, in the situations that I've been in where a child is a true harm to themselves, I needed someone else to call. And so a lot of this is just my personal experience. And so I wouldn't even say I've had these conversations. I think I was just listening to you guys talk and I was like, oh no, I don't like that at all. And so, it just kind of like, but I think we all agree, we were sent a survey recently, but from the state. And so IDOE sent a survey and I received a survey about what would it look like to have a crisis team that was available in these youth crisis situations. And I was so excited to see that because those conversations are being had at some level, right? And so I don't know what that's going to look like. It was a very broad question. There were like, I think 4 questions, and they were very broad questions around, would you take advantage of something, if a crisis team was available? What about virtually? What about in person? And, I just said yes, but it shouldn't just be available to like the schools or providers. It should be available to parents or caregivers or the community, right?
Right.
It should be it should be just like calling 911, right? Instead of, you're triaging, they're assessing, do I need to send an ambulance? Am I sending the fire department? Am I sending a police officer? Am I sending a social worker? And they're all separate entities, right? And sometimes
Right.
they get together. Sometimes they do get together depending on the situation, but sometimes they don't. Sometimes you're just going to get an EMT. Sometimes you're just going to get a fire department, someone from the fire department. Sometimes you're just going to get a police officer, and sometimes you just get a social worker.
Have there been any studies done to determine how many crisis calls police officers respond to that might fall within the purview of a social worker? Do you know of anything out there? I have not.
Yeah.
I mean, I've been kind of looking around. I have not found anything hard in the way of we could alleviate police officers of X percentage of their calls.
Yeah. And so I'm sorry. I am not familiar with any study in particular. What I would say, though, is that local, and so I think we know, like, not everybody communicates, and communication has increased. I was just talking the other day about when I was a young new driver, I was able to do diversion programs in a couple different counties from getting tickets, speeding tickets, because they didn't talk to each other back then. They talk to each other now a little bit more. So they're talking a little bit more. But I would think about like gathering that data, and I'm sure local police like departments, the state police departments, and I am so sorry, I have a tickle in my throat. Track all that very specific data, and it could be very easily gathered to show this is the cost that would be associated to bringing on this different team, and this would alleviate this.
Well, and then the cost, the alleviation, if you will, you reduce the number of calls police officers are having to make. I think, I think that, just taking some of that off their plate might help them be more effective at the job that they're out there to do.
Yeah.
For instance, and you brought this up, we don't ask police officers to run into a burning building. We have firefighters for that job.
Mm-hmm.
We have street workers, and, we have other functions of government. And I think that, that might be worth something to look into. I might just reach out to the NIH and see if there are any comprehensive studies out there based on this discussion, and see if there isn't any data out there that we can look at. And if there isn't, we might start asking why this isn't being looked at.
Right.
Yeah.
And that might be something that will involve outreach to our sitting federal representatives.
It's a great time right now. Well, it's a great time in general to do it, but that's an active thing to do in regards to mental health, in regards to criminal justice reform, in regards to gun violence with including police officers. I think that would be a very good idea.
Yeah, and I think to speak to some of that more too is like, so in Lafayette in particular, LPD has a direct line to a victim advocate in domestic violence situations, and so that is a social worker who can respond at any time of the day at any hour, but they're called out by the police, right? They're not dispatched by 911. And so, what would it look like to then, you already have some of these things in place. It would just be this shift, right?
Right.
Calling the police officer, you call the victim advocate instead. And so that's like, that's definitely one area. And darn it, if I didn't forget my second point, there's just so much good stuff we're talking about, you know? Yeah.
And this
Well-
hour does go by very quickly. I want to give everybody a chance to make kind of their last comments about this topic. It is almost 8 o'clock right now. And also for the candidates, please point your constituency to your websites or other ways they can get a hold of you. I'm going to start with Kara, just kind of last thoughts about this topic. I know we could have talked about, I think we could have talked for another hour, guys. There was so much more we could have got to.
Mm-hmm.
So,
I'm really grateful to be a part of the conversation. I am really thankful to have candidates to support who are passionate about this as well, and open to hearing from people who are in the community and in the field, and who are going to be wonderful representatives of all of us.
Thank you.
Thank
Kara,
you.
for being with us. Yes.
Mm-hmm.
Loretta.
Okay. I would like to thank everyone for being here. Thanks, Kara and Joe and Kyle for moderating. One thing that I would like to see is I would like to be a state representative so I can support programs that provide early identification and treatment for children. Because I know, like with education, the earlier the better, the earlier to identify so they can get treatment. And that includes supporting universal pre-K. They have the support they need earlier in life to where they may not, it might help prevent some of the mental health issues that come about from things like trauma and anxiety. So you can find out more about me at my website. It's lorettabarnes4indiana.com. And thanks for having me on this important discussion.
Thank you, Loretta. Joe.
Kara, thank you very much for joining us tonight. It was really kind of educational, and I enjoyed that opportunity as well. Loretta, my friend, I know we're going to see each other on Sunday, I believe.
Yes.
And I look forward to that opportunity. We don't get a chance to see each other enough. And Loretta and I are friends, and we've both been on the campaign trail. And so our paths finally cross, and I'll see you Sunday.
Yes.
And I am Joe Mackey. I am running for Congress in Indiana's 4th Congressional District. And you can learn more about me at joe4hoosiers.com. That's Joe, 4, Hoosiers.com. Stop on by our website, take a look, and reach out to us. Thank you.
Well, and that concludes our forum for this evening. Have a wonderful evening, everybody. Thank you.
Thank you.
Thank you.